Please go ahead, sir.
Good evening, friends. Today our guest speaker is Dr. Michael Daniner. He'll be lecturing on CML, an update from ASH 2021. This webinar is brought to you by Mumbai Hematology Group. It is supported by Zydus and managed by Mice Ideas. Good evening, friends. I thank Mr. Ashish and his team from Zydus, Rajesh Kalpesh and their team from Mice Ideas, Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. Michael Daniner, all our discussants were themselves eminent hematologists, medical oncologists, you participants for sparing your Saturday evening. Tomorrow morning at 11:30 a.m., we have Professor Tulika Sheth from AIIMS, New Delhi, speaking to us on public health physician, 2 heads, 1 mind. And midweek, we have a long marathon webinar of 3 days from Wednesday to Friday, 12th to 14th of Jan on sickle cell disease. And we have 6 eminent speakers from US and UK speaking to us. Dr. Gladwin will be speaking on cardiovascular complications. Dr. Woon on sickle cell disease as a prothrombotic disorder. Dr. Oteng from London on pregnancy in sicklers. Dr. Sophia on managing adult sickle cell disease. Dr. Deepa on novel therapies, Dr. Lakshmanan on bone marrow transplantation and sickle cell disease. This is Wednesday to Friday, 12th to 14th of January in the evening from 6 to 9. Our discussions today, we have hematologists and medical oncologists from Lucknow, Jaipur, Jabalpur, Delhi, Raipur, Kolkata, Surat, Ahmedabad, Hyderabad, Secunderabad, Chennai, Karnataka, and Bangalore. To introduce them to you, you know all of them. Dr. A.K. Tripathi, Professor and Head Department of Clinical Hematology at King George Medical University, Lucknow. Dr. Hemant Malhotra, Professor and Head Department of Medical Oncology, Mahatma Gandhi Medical College Hospital, Jaipur. Dr. Roshni Pandey from Mahakoshal Hospital, Jabalpur. Dr. Gundeti from Nizam's, Hyderabad. Dr. Jayachandran from Cancer Institute, Adya. Dr. Akanksha Garg from GCRI, Ahmedabad. Dr. Karuna Kumar from Yashoda Hospital, Sikandarabad. Dr. Vikas Goyal from St. Jeevan Hospital, Raipur. Dr. Amit Khurana from Surat. Dr. Aditi Jain from Saptaja Hospital, Delhi. Dr. Nidhi Dixit from Apollo Hospital, Kolkata. Dr. Akshata Nayak from AJ Hospital Research Center, Mangaluru. Dr. Ankita Sen from Amri Hospital, Kolkata. Dr. Tejaswini from Majumdar Shah Medical Center, Bangalore, and Dr. Gunjan Prasad from Apollo Hospital, Kolkata. It's my pleasure to introduce Dr. Michael Daniner from Wisconsin, US today to you. He is not unknown to you. Besides his extensive contribution in the field of CML, he has been our faculty in past at multiple occasions. Just 6 months ago, he spoke to us in these webinars as well. To complete the formalities, he's Executive Vice President and Chief Scientific Officer, Varsity, Wisconsin, Director and Senior Investigator, Varsity Blood Research Institute, Professor, Division of Hematology and Oncology, Department of Medicine, Associate Dean for Research, Medical College of Wisconsin, US. He is HCL investigator and member of the Experimental Therapeutics program. He received his MD from the University of Würzburg Medical School, Germany, 32 years ago in 1990. In 1995, he obtained a grant to enroll in the PhD program at Imperial College London. His thesis work focused on signal transduction and the potential use of imatinib as molecularly targeted therapy for CML. Subsequently completed a fellowship in BMT at the University of Leipzig Medical Center. In 2002, he was recruited to the Division of Hematology and Medical Oncology at Oregon Health and Science University as assistant professor. In 2007, he was promoted to the rank of associate professor and became the head of the hematological malignancy section at Oregon Health and Science University. 2010, he became the M.M. Winthrop Professor of Medicine at the University of Utah and was appointed Chief of the Division of Hematology and Hematological Malignancies. In 2018, he was selected as the inaugural director of the Huntsman Center for Excellence in Hematology and Hematological Malignancies. His work encompasses over 250 articles in the peer-reviewed literature, including journals like Cancer Cell, Blood, Journal of Clinical Investigation, and NEJM. He's co-authored over 10 book chapters and with contributions in leading textbooks such as DeVita's Principle of Oncology. He's a regular speaker at almost all major international scientific meetings such as ASH, EHA, and a peer reviewer for journals like Nature Genetics and Cancer Cell. His honors include the Alexander Kefalides Prize for Leukemia Research, membership on the editorial board of Blood, Thomson Reuters Highly Cited Researcher Award 2014 and 15, the Janet Rowley Award in 2019, the H.A. and Edna Benning Presidential Endowed Chair in 2020. He serves as the chair for NCCN CML panel and is a member of the NCCN MPN panel. Since 2016, he has been serving as a permanent member of the Developmental Therapeutic Study Section, Center for Scientific Review, NIH. I'm privileged to invite him to deliver his talk on an update from ASH on the subject of chronic myeloid leukemia, which is so close to his heart. Thank you. Over to you, sir.
Okay. Hey, thank you, Dr. Agarwal. That was way too much praise, I think. So I'll share my screen now. I think this is the right one here. Yeah. So ASH 2021 in terms of CML was, I would say, interesting, but it wasn't revolutionary. So what I've done is really I have two parts of the talk. The first one is in a presentation of data that were presented at ASH, which will be, I guess, about 20 to 25 minutes. And then if there's interest, I have a second part of the talk, which is talking a little bit about the management of advanced phase CML, so accelerated phase and last phase. And I wanted to ask, how much time do I have, or how long am I supposed to talk?
So as much as you want. We are here only for you.
Don't tell me I can't go on forever. So as you know, I've been interested in CML for a long time, and I just want to use these opportunities to give credit to the many people who have contributed to CML over really 170 years, starting with Alfred Donnet in Paris, who probably was the first person to see blood cells under a microscope. And he very presciently suggested that there is different stages of maturation in the cells he saw. One of his disciples was Hughes Bennett, who described what was probably CML in a patient in 1847. At the same time, almost the same time, in fact, just 6 weeks later, Rudolf Virchow in Berlin published a case that what probably also represented CML, but he recognized that this was probably a neoplastic disease rather than the infectious process that Bennett had thought about. And then over the next really almost a century, not that much happened, except that Neumann found out or reported that blood cells probably originate from the bone marrow, which really hadn't been known for quite a while. William Demeshek in the 1940s and 50s developed the concept of myeloproliferative disorders, recognizing that all these disorders, including CML, share a lot of commonalities. But it was still not clear whether they are neoplastic or whether they are clonal or not. That became clear with the discovery of the Philadelphia chromosome by Nowell and Hungerford in 1960. That really is a landmark, because at that point it was still thought that cancer may have to do with proteins transmitted from one cell to another. But the discovery of the Philadelphia chromosome made it very clear that this is a DNA problem. Ironically, at about the same time, in fact, a few months later, a group in Edinburgh reported really exactly the same findings, but this manuscript is now largely forgotten. So first come, first served in science many times. Fred Fialko recognized that CML is a clonal disease and that it really originates from a single cell using G6PD genotyping to deduct that the CML cells in female CML patients have expressed the same G6PD isoenzyme. And since G6PD is localized on the X chromosome, if there is only one type of enzyme expressed in heterozygotes, you can conclude that all the cells need to have originated from the same parental cells. Janet Rowley in Chicago in 1973 discovered that Philadelphia chromosome was really not just a single abnormality of a single chromosome, but there was a translocation between chromosomes 22 and 9 and 22. Nora Heisterkamp then together with Jim Griffin and others discovered that the translocation co-localized the BCR and ABL1 genes in the derivative chromosome, Philadelphia chromosome. Eli Kanani contributed to this work, and then there was this guy here, Alexander Levitsky in Jerusalem, who was the first one to suggest that inhibitors of the ABL tyrosine kinase might be useful to treat patients with leukemia based on activating ABL proteins. And the rest is kind of history. This is Alois Meller from Switzerland, who's not recognized a lot, but he was really an ingenious chemist who developed a series of tyrosine kinase inhibitors, including imatinib. Nick Leiden was the key driver of this program at Novartis Pharmaceuticals, and as you know, Brian Drucker was able to convince the manufacturer to put that into a clinical trial. So a lot of people have contributed to that, certainly, of course, beyond the ones shown here. So this is a good history of a disease that until maybe 25 years ago was still extremely difficult to treat, leaving allogeneic stem cell transplant as the only curative option for patients with an overall survival of the entire population in the developed world of approximately 5 years. So let me review some of the data on CML that were presented at the ASH 2021 meeting. The first abstract that I will discuss is an update of the ASSEMBLE study presented by Dr. Morrow from Sloan Kettering Memorial Institute. The ASSEMBLE trial is a randomized trial between bosutinib and asciminib in patients who failed at least 2 tyrosine kinase inhibitors, so in other words, third-line treatment. The primary endpoint in this trial is major molecular response. And the results of this trial have led to the regulatory approval of asciminib in the United States in September of 2021. So this is now follow-up at 24 weeks, with an overall duration of follow-up, median follow-up of 19.2 months. Already mentioned the primary endpoint, MMR at 24 weeks. And key secondary endpoint is MMR rate at 96 weeks. Key entry criteria, at least 2 TKIs before and chronic phase CML, failure or intolerance to the prior TKI, and the need to have a BCR-ABL expression on the international scale of at least 0.1%. Patients with T59 or V299L mutations were excluded, which is, of course, somewhat problematic because people have questioned the validity of a trial comparing asciminib versus bosutinib, because we would consider ponatinib the most potent and the probably best third-line inhibitor. But since bosutinib, since the dosing for ponatinib wasn't clear at the time of initiating this trial, bosutinib was chosen as a control arm. So I think we always have to kind of bear that in mind, that it is probably not the optimal choice. Patients were randomized between asciminib 40 milligrams twice daily and bosutinib in a 2-to-1 fashion. And then this is, of course, very straightforward. Now, this is the MMR rate at now 48 months, about 30% for asciminib and 16% for bosutinib. This hasn't changed a lot compared to the 24-week follow-up. So it indicates that responses, if they are achieved, tend to be achieved quite early on. If you look at patients who achieved a complete cytogenetic response, or the equivalent of it, that is an BCR-ABL ratio of less than 1%, it's 42 versus 19%. If we look at deeper responses, so MR4 or MR4.5, it's evident that this is only a minority of patients, so 10% in asciminib, and then only a very small fraction in bosutinib-treated patients. Now, I think I would take that with a grain of salt. This may still improve with time, but it's unlikely to go over the 30% of MMR rate we see at the moment. So, in other words, there is really a limitation in these heavily pretreated patients in terms of achieving deep responses on asciminib, and to me at least, these data look not quite as good as the data with ponatinib. But take it with a grain of salt. We do need longer follow-up here. Adverse events. This is all grade. This is grade 3 and 4. I think not really too surprising for a trial in heavily pretreated patients. Adverse events leading to discontinuation are actually really rare in asciminib, but fairly common in the bosutinib arm. In bosutinib, as is in consistence with prior results, most of the AAs leading to treatment discontinuation are hepatic toxicity. Otherwise, nothing too much nothing too surprising. So a little bit of hematologic toxicity, but all in all, these two drugs are relatively well tolerated. There are a few trials in progress extending on the findings in asciminib. This is the FORCE-CML or AIM-FORCE-CML trial. This is really a phase 3 trial that extends on the initial phase 1 study. It has 2 cohorts, 2 doses of asciminib, and then a 3rd dose of asciminib specifically for patients with the T59 mutation. I'm not convinced that we'll learn all that much from this trial because the projected patient enrollment is relatively small. The approved dose of asciminib is 40 milligrams BID. Is 80 milligrams BID. So I'm not quite sure whether we'll learn a lot from this going back to the phase 1 and testing more patients with 40 milligrams BID. As you know, the T59 mutant is relatively resistant against asciminib, and so these patients are typically treated with the highest dose tested, that is 200 milligrams BID. And I personally think it might well make sense to try this dose in patients with other mutations. And the reason for that is that, as you see, this rate here, the MMR rate, really hasn't moved. And so this is probably a ceiling that we see, at least in the advanced phase or late chronic phase CML setting that we see with asciminib. There is another trial, which is basically a frontline trial. That is a randomized phase 3 trial of asciminib versus investigator's choice. This is a 1-to-1 randomization. Asciminib will be used at the standard dose, and there are multiple endpoints or primary objectives, but the most important one is the rate of MMR at 48 weeks. So study population is, as I said, newly diagnosed, and it will at least tell us about the efficacy of frontline or of asciminib in the frontline. There were several reports on asciminib in real-life populations. This is a study that looked at 49 patients treated with asciminib with 40 milligrams twice daily at a number of institutions. And if you just look at the results here, so this is only patients without response at baseline. There is a 40% rate of complete cytogenetic responses and a 49 or 39% rate of major molecular responses. So I think this is pretty comparable to what we've seen in the phase 1 study and also in the ASSEMBLE trial. Another study looked at 22 patients. This is from Canada. And I think we just look at the responses here. There were several patients here now pre-treated with ponatinib, and a total of 18 with a T59 mutation. So, without the T59 mutation, and 4 with the T59 mutation. So that means that different doses were used in these trials. Now, if you look at the MMR rate at 6 months, that would be comparable to the equivalent to the endpoint of the ASSEMBLE study. We see 18% overall response with more or less comparable results across the different cohorts here in what is a relatively small study. If you look at cumulative MMR rate here, it again has a ceiling at approximately 30%. So that seems to be a little bit of a ceiling in heavily pretreated patients. Another study, basically also retrospective, observational from the Russian Federation. Here, 46 patients. And if you look at the response rates, CCYR in 32%, MMR 34%, and MR4 in 17%. Now, they did a multivariate analysis, and they found that, univariate analysis, they found that a higher pre-therapeutic expression of BCR-ABL is associated with a lower likelihood of responding. And I think this is confirmatory of observations that have been made by other people. An interesting molecule is HQP1351, or now also known as olverembatinib. This is a TKI first reported, I believe, a couple of years ago from the People's Republic of China. And this is an update of the phase 1 results. I think this is an interesting molecule. So let's look at the data here. So this is patients with chronic phase with the T59 mutation. And what you look at here is CHR, CCYR, major cytogenetic response, and MMR. So there is a surprisingly high rate of MMR. And I believe this is cumulative MMR in patients with a T59 mutation. So I think this is efficacy that is at least equivalent to what we would expect from ponatinib, probably superior to that. Now, conversely, patients without the T59 mutation seem to do not as well, with a fairly steep drop-off of complete cytogenetic response, and even more so major molecular response. So I think more to come. There is a phase 2 and phase 3 trial ongoing at the moment, but this drug could turn out to be a molecule that has really an astounding potency against the T59 mutant, which may in the future be a competitor versus ponatinib, with the caveat that it does have apparently more liabilities in patients without the T59 or with mutations other than T59. So I presented a post-hoc analysis of the OPTIC trial. The OPTIC trial was a study, or it is still ongoing, is a study of ponatinib in late chronic phase, patients who had failed multiple TKIs. The interesting part of the OPTIC trial is that it really has a dose de-escalation strategy built in. So in other words, as soon as a patient achieves a target response, there is a mandatory de-escalation of the dose. And of course, the thinking behind it is that this might increase the tolerability and reduce cardiovascular side effects of ponatinib. So the way it's designed is that everybody starts at 45 milligrams, but then there is a dose reduction to 15 milligrams as soon as patients achieve the equivalent of a major of a complete cytogenetic response. Now, what we've done in this post-hoc analysis, which is really post-hoc, so there are no p-values provided here, is to see in which way the baseline mutation status or the baseline expression of BCR-ABL influences results. This is just to repeat the design once more: 45, 30, or 15 milligrams as the starting dose, and then there's reduction to 15 milligrams as soon as a patient achieves a complete cytogenetic response. In the case of patients who are started on 15 milligrams, there is an option to reduce to 10 milligrams, but only if there are adverse events. These are the baseline characteristics. I'll pretty much skip over that. They are really pretty well distributed over the three groups here. Now, if you look at mutation status, there is perhaps a little bit of an imbalance here. There's 359V quite frequent in the 15 milligram cohort, and G250E quite frequent in the 45 milligram cohort. But I think we would not expect this to make a really dramatic difference. Now let's look at the starting BCR-ABL expression and its impact on response. So this is basically broken according to more than 10% and less than 10% BCR-ABL expression. And now we look at the high dose group, if you will, starting at 45 milligrams, and you see that the overall response rate in terms of the major endpoint is 51 and 68% respectively. Now, if you go to 30 milligrams as the starting dose, you see practically no change in those patients who have relatively low BCR-ABL expression, but you do see a drop-off in the patients who have a relatively high level. If you go down to 15 milligrams, now this drop-off seems to affect also patients with a relatively low expression of BCR-ABL. So it really matters. If you have relatively low expression of BCR-ABL, 30 milligram is a good starting dose. If you have more than 10%, then you should definitely start with 45 milligrams. Similarly, you can look at the baseline mutation status. So either no mutation, T59, or another mutation. In the case of the 45 milligram starting dose, no difference. In 30 milligrams, the T59 mutant group starts to decline, and I think quite dramatically. And this further accelerates if you look at the T59 mutant patients in the 15 milligram cohort. So I think that really indicates that patients with T59 definitely require a starting dose of 45 milligrams. If you have another mutation or no mutation and your BCR-ABL level is less than 10%, you can pick 30 milligrams. Otherwise, you also have to go with the 45 milligrams. 15 milligram has some efficacy, but I don't think for general purposes it can be recommended unless there are very strong driving factors, so comorbidities that would cause you to do that. If we look at progression-free and overall survival, progression-free survival is, I would say, okay. There's clearly attrition of this cohort here, and that is across all of this population, and that seems to be across all three cohorts. Overall survival is looking favorably, which I always find somewhat surprising because we tend to think that patients who have failed 3 or 4 TKIs, even if they are in chronic phase, and then don't achieve major molecular response or even deep molecular response or complete cytogenetic response, have a very high risk of progression. But my impression here is that that doesn't seem to be the case. So I think these TKIs do have a stabilizing effect, even in patients who do not achieve deep responses. This is now progression-free survival according to dose and mutations. No big difference according to dose. A more significant difference according to dose in the T59 positive cohort, where those patients with 45 milligrams starting dose do better. And then progression-free survival in patients with mutations other than T59. Again, no difference. So long story short, what you need to look at is the presence or absence of a T59 mutation and the baseline expression of BCR-ABL. And this is just now overall survival, which is sustained across these cohorts, irrespective of mutation status. Sorry. Not sure what happened. Just see if I can move this. Yeah. Now looking at safety, and here I would like to focus on the treatment emergent arterial occlusive events. You see 10% here in the high dose cohort, 10%, excuse me, 9 events, 10%. In the 45 milligram cohort, 5 and 3% in the 30 and 50 milligram cohorts, respectively. If you look at serious treatment emergent arterial occlusive events, however, there doesn't seem to be a significant difference. This is all in all consistent with the notion that this dose de-escalation strategy based on response really works. And as such, the trial has really quite a bit of innovation to it, because I think this could apply to other scenarios as well. So for instance, you could think about nilotinib, which also has cardiovascular toxicity. And the question would be whether it would be okay to reduce the dose as soon as you achieve a desired response. And of course, we'd like to do these trials, but I think the community has so far not been able to do them. Another interesting abstract from the meeting is the final analysis of the EuroSKI trial. You will remember that this is a large European study, multi-centric, that looked at the outcomes of treatment-free remission in what is more a real-world setting. This trial has been published initially, I believe, in 2018 or 17, and now this is the final analysis, including all the patients. It's a large study with 868 patients, 728 are eligible. The mean duration of treatment prior to enrollment was 7.5 years, and the mean duration of MR4 before TKI cessation was 4.7 years. 36 months, 678 patients were analyzable. 309 of these patients were in major molecular response, which represents 46%. And with that, the null hypothesis was rejected. So in other words, the strategy was deemed effective. Median recurrence-free survival at 36 months was 48%, and molecular recurrence and treatment-free survival was 46%. There was no transformation to blast phase. Now, I think you know that this trial has been published before, and the two parameters that are associated with successful TFR is the overall length of TKI therapy, as well as the length of duration of deep response. What this curve shows here is, I would somewhat reassuring, because if you look at this drop off here, this is what we've seen with practically all the TFR studies. But unlike many other studies, there was no plateau after 18 or 24 months. In contrast, there was continuous attrition of this curve, but there is now evidence of stabilization. So maybe there is a plateau after all, although it does occur at a later time point compared to other trials. What the reasons for that are is unclear, but there is a suspicion that in this more real-world setting, the eligibility criteria for patients may not have been as stringent as they were in pharmaceutical company-sponsored trials or other trials prior to that. So there may be patients in this cohort whose molecular response and deep molecular response was not as stable due to the lower consistency of pre-enrollment testing. But it's really hard to say that. One, I think, interesting approach that is currently enrolling, so I wanted to mention that, is a combination of TKI with an MDM2 inhibitor. MDM2 is an E3 ligase that leads to degradation of p53. And so in CML, particularly advanced CML, p53 is rarely ever mutated, but frequently downregulated at the protein level as a result of degradation. So in other words, there's a relatively straightforward strategy to re-establishing p53 expression by inhibiting MDM2. So this trial here will look at an MDM2 inhibitor that is added onto the existing TKI. So somebody is on a TKI, fails it, and then you add in this molecule to see whether you can re-establish response. I think this is one of the trials that I personally think is more promising in the CML world at this point. So with that, I conclude this short overview over the ASH 2021 results, and I have put together a few slides on the management of advanced CML. I will say that in the United States, where we have the privilege of a very well-funded healthcare system, advanced CML is relatively rare. But I believe in the less fortunate part of the world, this is much more common, so it may have some relevance to your setting. One of the issues that we have to contend with is that the definitions of accelerated phase and blast phase are variable according to the various bodies who report these definitions. This is the NCCN definitions for accelerated phase that really follow what has been published by the MD Anderson Cancer Institute a number of years ago. Platelets less than 100, blasts and in the peripheral blood or marrow 16 to 30%, blasts and promyelocytes more than 30%, basophils more than 20%, or clonal cytogenetic evolution in the Ph positive population. Blast phase defined as more than 30% blasts. Now, if you look at the WHO classifications, on the other hand, you have this old listing here that I personally think is not very helpful because it's not quite clear what increasing splenomegaly, sorry for the typo here, means, and what an increasing white count means in spite of therapy. So I think this definition is not too useful in the TKI world. On the other hand, blast phase is defined according with the general definition of AML, but that is problematic in as much as a threshold of 30% and to define blast crisis was used in literally all the blast phase trials. So in other words, all the data we have are based on this definition. So I think it's pragmatically better to stick with the 30% at this point. I guess what we'll see as time goes by is that advanced CML will be defined more in terms of having failed prior TKIs. So that is a, if you will, a biological test for advanced phase disease that at the time of making these definitions here was simply not available. So I hope this will change. Another question is whether we should really still talk about accelerated phase versus blast phase. And I think this is based on the notion that the gene expression profile of advanced phase CML is different from chronic phase CML, but it is not really different between accelerated phase and blast phase. This is data published quite a few years ago by Cherry Radich. And it's basically looking at chronic phase and accelerated phase and blast phase. And as you see, this is really a continuum, if anything, and chronic phase seems to cluster in this lower part here, whereas blast phase and accelerated phase clusters in the upper part. So the question is, does it really make sense to talk about accelerated phase versus blast phase based on morphological definitions? Another interesting observation that Cherry made here is that patients with who have failed TKIs, irrespective of whether they are accelerated or chronic phase by morphological criteria, sit in this accelerated or blast phase bucket here. So in other words, once you've progressed, even if there's a second chronic phase morphologically, the adverse gene expression profile is maintained. Now, I'm sorry, this has stopped again. Let's see. Okay, so a few years ago, we looked at that in a study where we looked at CD34 positive cells from imatinib naive patients. And we grouped these patients according to whether they achieved a complete cytogenetic response or not. And then we compared the profile of patients who did not or did achieve a complete cytogenetic response with published signatures of chronic phase versus blast phase, or of long versus short chronic phase. And we found that the signatures do overlap in a significant way, which really confirms what I've shown on the previous slide, that there is a great deal of similarity between blast phase, non-response to TKIs, and high-risk chronic phase. So the scenarios of advanced phase CML as they present themselves nowadays are primary acquired TKI resistance, but still chronic phase criteria met, accelerated or blast phase at diagnosis, and TKI resistant CML in accelerated or blast phase. So if you look at primary acquired TKI resistance, then ponatinib seems to be an extremely viable option. This is progression-free survival and overall survival in the PACE trial. This is 5-year follow-up. And if you look at overall survival, it's around 80%. So really an acceptable overall survival, I believe, given that many of these patients had failed 3 or 4 TKIs. So I think for chronic phase, failure of multiple TKIs, you have a good option. And I think this will now be improved even more with the advent of asciminib. Now, what about blast phase, accelerated phase at diagnosis? Now, in the United States and Europe, this is relatively rare, but in India, for instance, this seems to be quite frequent. And I think you, of course, know a lot better about this than I do. But it would suggest that many of these patients are seen relatively late. People have suspected there may be biological differences, but I would suspect this may well reflect more the socioeconomic circumstances of these patients. Now, if we have a newly diagnosed patients, it is really important to make sure that that person is still in chronic phase. And at the very minimum, of course, we should do these tests here: complete blood count, metabolic profile, and bone marrow aspirate, but also still conventional cytogenetics. There are optional tests like a bone marrow biopsy. Sometimes you will pick up some nests of blasts in what otherwise looks like chronic phase CML. And if you want to have a baseline BCR-ABL level, that may be useful in some circumstances, but it's not really necessary. In some situations, you will require FISH to make a diagnosis, flow cytometry to, if you suspect already progression to blast phase, in HLA typing, if you consider stem cell transplant. Now, why is baseline cytogenetics still relevant? I think it is because the major route abnormalities, classically defined as a second pH +8 +19 or isochromosome 17, do confer significantly inferior outcomes. This is data from the German CML4 trial that shows you basically imatinib outcomes. The problem is that we don't have this data available from any of the other big trials. So neither from the NSDNT trial of nilotinib, nor from the Decision trial, or from the BELA trial, or before trial of bosutinib. It would be really nice to analyze that, but so far I wasn't able to convince the pharmaceutical companies to do that, because I think it would be really important to understand whether a second generation TKI is able to override the adverse effect of these cytogenetic abnormalities if they are present at baseline. I think this will be enhanced in the future by doing next generation sequencing on myeloid malignancies associated genes. And the prediction would be that at least some of these abnormalities, specifically ASXL1 mutations, may also confer an adverse outcome. Now let's look at the arguably most difficult groups. So these are patients who failed TKIs and are in accelerated or blast phase. This is MD Anderson data, a large cohort of more than 400 patients. They found an overall survival of 12 months, failure-free survival 5 months, myeloid phenotype, prior TKI, older age, high LDH, low platelets, and progression from a preceding chronic or accelerated phase are poor prognostic factors. Favorable prognostic factors are achievement of a complete cytogenetics response on treatment, and importantly, the combination of TKIs with chemotherapy. I think there is still some contention around this. If you have a patient who progressed on a prior TKI to accelerated phase or blast phase, what exactly should you do? So should you have, if you still have a TKI in reserve, such as ponatinib, I think it's sometimes debatable whether you should really treat with chemotherapy at the same time. And the reason for that is that the toxicity of chemotherapy in this setting is considerable. And if you consider a stem cell transplant as a definitive treatment, then the adverse events and side effects of intense chemotherapy can make this transplant more difficult. So I would still hold that this is a situational and individual decision that we need to make for these patients. Fortunately, overall transformation to blast phase is quite significantly reduced compared to prior years with the advent of TKIs. So fortunately, this is now a pretty rare event. However, if it does happen, then these patients don't do well. This is overall survival after progression in the NSNT and IRIS trials. And as you see here, the overall median overall survival is only about 9 months. If you have this situation, then in my opinion, these individuals need to go on some kind of a ponatinib-based regimen. In accelerated phase CML, this is still acceptable, I guess, not too bad. We're looking at overall survival here, which is about 50% at 36 months. If you are in blast phase or Ph positive ALL, then your window of opportunity is quite short. So see, some of these patients will achieve a response, but literally everybody will relapse eventually. So there is only a small window to do something more definitive like an allo transplant. Now, what we've been interested in the lab is to understand resistance in these advanced settings. In this case, it is patients treated on the PACE trial. And so if you look at that, it turns out that approximately half of the patients relapse because they have a mutation in addition to the original mutation, or we call that a compound mutation. The other patients have mutations that should respond to ponatinib, and in fact, BCR-ABL is still suppressed, but yet have developed clinical resistance. So we refer to that as BCR-ABL independent resistance. These two scenarios are very different from each other because here you can deduce that there's very strong selection pressure or a need for the disease to reactivate BCR-ABL. So we know that BCR-ABL remains a very good target, whereas over here, it is much more complex and much more heterogeneous, and BCR-ABL may not be required anymore for the disease process. Now, we focused in our lab very much on these compound mutations, so more than one BCR-ABL mutation in the same molecule. It turns out that there is many different combinations, but the centerpiece in many cases is the T59 mutation. And it turns out that the T59 mutation in combination with almost any second mutation confers complete resistance against all TKIs, including dasatinib. So imatinib, nilotinib, I said dasatinib, but I mean ponatinib. So red means completely resistant, and you see that this is mostly red with a couple of exceptions. So this creates a situation where we actually know the target, it's BCR-ABL, but we cannot inhibit the target with currently available single agent inhibitors. Now here comes imatinib, comes asciminib back into the picture. As you know, asciminib is an allosteric inhibitor. It binds to this myristate pocket here at the base of the kinase. This is the kinase domain of BCR-ABL. This is the N lobe. This is the C-terminal lobe. This is the SH2, and this is the SH3 domain. So in its inhibited form, ABL and also BCR-ABL are in this conformation here, where the SH3 and the SH2 and the SH3 domain are flipped back onto the kinase domain. If you want to enable this conformation, what you have to do is stick myristate into this pocket. And myristate can essentially be mimicked by asciminib, re-establishing this physiological inhibited kinase state, kinase conformation. Asciminib, just to show that here, it really looks like a key. So this part of asciminib sticks out of the pocket and this sticks in, right? So it's really working like a key that you put into a lock. Now, what we've tested in the lab and also in vivo is whether combinations of ponatinib and asciminib are synergistic. And it turns out they are surprisingly synergistic. I show that here. What you look at is the IC50, so the concentration of drug required to achieve 50% inhibition. And let's look at these two mutations here that contain T59 and that are very resistant against ponatinib. So with the IC50 here at 400 or 600 nanomoles, which is way really tenfold more of what you can achieve in the plasma of patients. However, if you add a little bit of asciminib, this is greatly lowered, close to achievable or below achievable plasma concentrations. This is basically another look at the data. There are T59 inclusive compound mutations. There are non-T59 inclusive compound mutations. And you see that the ponatinib-asciminib combination is in literally all of these cases a lot more efficacious than each single agent alone. One way of looking at that in a more prospective way is to do a mutagenesis assay. So basically you use a cell line that expresses BCR-ABL and you treat it with strong mutagen like ENU to induce multiple point mutations. And then you treat these cells with an inhibitor and you wait which clones grow out. Now, if you do that with asciminib or ponatinib alone, it is no problem for this cell line to grow out a few resistant clones. So ponatinib, for instance, you go from here to here, and you see there's resistant clones. However, as soon as you start to add asciminib, you suppress the outgrowth of resistant clones. So the synergistic effects of these two inhibitors is very strong towards the emergence of compound mutations or of resistance mutations in general. This is in vivo data now looking in mice. This is ponatinib alone, asciminib alone, and the combination. You see that the combination is more effective than each single agent, and that leads to a slight prolongation of survival. I know that Brian Drucker at Oregon has treated a patient with a compound mutation with a combination of the two drugs and was able to re-establish a complete hematologic response. We have worked very hard to convince Novartis to allow us to run a trial with this combination in patients with accelerated or blast phase CML. That hasn't happened so far, but I think they have more recently warmed up a little bit more towards this concept. So we'll see. Mechanistically, what we believe is happening is that these compound mutations just create incredible instability in the kinase. So blue in these diagrams here means the molecular movements are not coordinated. So in other words, there's incredible flexibility here. What we think happens in the combination is that ponatinib initially binds and stabilizes the kinase such that this pocket here can be formed, the myristate pocket can be formed. Then asciminib comes in, stabilizes this conformation, and allows additional ponatinib binding until the molecule gets inactivated in successive cycles. Of course, in addition to BCR-ABL, there are multiple mutations in blast phase CML. This is from a paper published by the Australians 3 or 4 years ago. These are the kinase domain mutations, but there's a whole range of other genes that are mutated, typically not in any way, in any predominant way. And I think this is one of the challenges with blast phase, that it is genetically very heterogeneous. So I suspect that in blast phase in general, but in particular in those patients who don't have explanatory kinase BCR-ABL compound mutations, epigenetic therapies that give you a broad sweep have essentially, or can have effects on multiple mutations, will be the way to go. It'll be very difficult to come up with one uniform targeted approach. Of course, multiple studies have been performed, unfortunately, mostly preclinical. And so it's, at least here in the United States, very hard to do a trial in blast phase at the moment because the patients are rare. So maybe that is something that you in your country would be much better positioned to do. And with that, I just want to thank all the people that I had the privilege to work with over many years of being involved in CML. And I want to thank the International CML Foundation for their inspiration and support. And with that, I think it's question time, and you should feel free to ask as many as you want.
Thank you so much, Dr. Mike. That was wonderful update, beautifully delivered. Learned a lot. Now we have our Indian colleague who would like to ask their difficulties and interact with you. So we start with the Dr. Anil Tripathi.
Yeah. Hello, Mike. It was wonderful talk, and you have very beautifully covered every aspect. But one aspect you did not cover is to how to increase the TFR, because our aim is to molecularly cure the disease rather than putting a patient to take the drug lifelong. And you see that these newer TKIs also have significant side effects. So what is being done in terms of directing leukemic stem cell so that we can have a durable molecular cure in patients who stop the treatment?
Thank you for asking this question. There is plenty of preclinical data that suggest a variety of concepts to be able to target CML stem cells. Very few of these studies have been implemented in clinical trials. I think this is a big problem in the entire field. So we have plenty to test, but we have very, very few trials. And many of these trials are performed not in patients with residual leukemia, but in patients with resistant disease. So a negative readout may not necessarily tell us about what would happen if patients were not in advanced stages of CML. So I will say that several concepts are being tested at the moment. So one is a combination of asciminib with imatinib in patients who have failed one TFR attempt in the hope of achieving a deeper response prior to a second attempt. This would still be essentially targeting BCR-ABL, but may have some validity. I think one thing that we haven't really exploited is how far we can get with inhibiting ABL up front. If you look at the data from the EPIC trial that was ponatinib in the front line, there is not a lot of follow-up because the trial was stopped. But the deep molecular response rate in patients on ponatinib 45 milligrams up front is quite amazing. So I don't totally recall the numbers now, but I think it's in the range of 50% or so at 12 months. So it is possible that just inhibiting BCR-ABL with a very, very strong inhibitor or combination would get more patients into deep response, or maybe the majority or vast majority of patients into a deep response. And then, because we would hope that we will maintain the approximately 50% success rate. So that's one approach, basically making more patients eligible. Second approach is to combine a TKI with yet something else. And I think here there are just multiple options. There is one trial looking at a combination of a TKI, a BCR-ABL TKI with ruxolitinib, based on evidence that JAK signaling maintains survival of stem cells. That trial is ongoing, but I don't think the data look very good at this point, although a prior study actually looked more promising. Another trial that has delivered something is the Choices trial. So this is a combination of BCR-ABL TKI with chloroquine as an autophagy inhibitor. That trial has read out negative, although there are some suggestions that maybe with more optimal dosing, one might be successful. Yet another trial is the use of, I'm just blanking out on the name, I'm sorry, it's an anti-diabetic in patients with residual CML. That trial has read out negatively.
Pioglitazone, that is pioglitazone, right?
Yeah. So I think I'm probably not really answering your question. I'm sorry.
You're very well answered. Yeah.
Yeah, I think we just need to do these studies, because I mean, until we try it in the clinic, we really don't know what's going to work. And so we're just not very good at it. I'm in Milwaukee now, and Dr. Atala has organized a CML network. So the hope is that we'll just be able to accrue better into these trials as we have more centers and also people who are really good at working together.
Okay. Thank you. Thank you.
Thank you. We'll come to Dr. Sadashivdu. Before that, I will ask one question from the audience. Dr. Krishna Ratna wants to know, are there any mutations in BCR-ABL which are resistant to asciminib?
Yeah, there are several mutations that have been found in the myristate pocket. So the residues lining this pocket, and they do confer resistance to asciminib. However, it's been relatively rare so far in the clinical trials. So really just a handful of mutations. There's also, what I've seen is an analysis of the ASSEMBLE study of patients who failed asciminib. And it seems that there are mutations in the SH2 domain that are associated with a level of resistance to asciminib. So answer is yes. Some may be quite expected because they are sitting where the molecule binds. Others may be harder to explain on a mechanistic basis.
Thank you. Dr. Sadashivdu, your question.
Yeah, thank you, sir, for wonderful lecture. Just I have one question regarding this toxicity profile of this asciminib, especially in ASSEMBLE trial. So the toxicity is very common if we have used a prior TKI like Tasigna, there's nilotinib. So we have seen more cardiotoxicity or something thrombotic events. So if we combine with the asciminib with any other second generation or third generation TKI like ponatinib, do we have the more toxicity of thromboembolic events or myocardial events? So do we have any such guidelines to choose these drugs before we start this, even though more efficacious but highly toxic to prevent this cardiac morbidity or thromboembolic morbidity?
I think there are two answers to that. One is, as far as the question is, if somebody had a prior cardiovascular event, would that patient be at higher risk of having another event on asciminib? And I suspect probably yes. And I would also be surprised if asciminib had absolutely no cardiovascular toxicity. And there are some subtle signals in the phase 1 study and in the ASSEMBLE trial as well. So I think we need to observe that closely. Now with combining, I would think they could go in two ways. If you do combine with nilotinib, I think you have the same nilotinib-associated toxicity that you have with single agent, if not more. If you combine with, say, ponatinib or with dasatinib, the question may then be how much of this thromboembolic toxicity is related to inhibiting ABL. Because I think what we've all thought is that this is off target. So it's related to inhibition of vascular system kinases. But I think there are a lot of questions about that because in the solid tumors, sunitinib, for instance, always is also a strong VEGF inhibitor. But you don't see these vascular events. You see hypertension, but you don't see these vascular events. So maybe it does have to do with inhibiting ABL. And if so, then it's a class effect. And I think if you try to hit ABL really hard by combining two of these inhibitors, we're just going to see more toxicity. So yeah, I think absolutely possible, I would say. Good, very good question. Thank you.
Thank you, sir.
Thank you. Dr. Roshni will be coming to you, but we'll take one question from the audience before that. Dr. Ashwin Nair wants to know that if a patient of CML at initial presentation has 10 to 20% lymphoblasts in the bone marrow, what is your approach to the treatment?
I would treat that patient like lymphoid blast phase. So, yeah, it doesn't meet the blast phase criteria that I showed you at length, but I think this is blast phase.
Thank you. Dr. Roshni, your question.
In patients who have additional cytogenetic abnormalities at diagnosis, as you had alluded to, since the data for second generation TKI is not very strong, is there any role for giving high dose imatinib? And second question is, how do we monitor these patients?
High dose imatinib. Answer is I don't know. I would probably, if you have access to a second generation TKI, that would be my preference. Just looking at the imatinib data, the average imatinib dose in this German CML4 trial is around 600 milligrams. So it's a little bit more than the 400 standard dose. And still you see this pretty significant effect on overall survival. So I would think imatinib is not the first choice. As far as monitoring is concerned, yeah, you may be down to repeating cytogenetics once in a while. Of course, there can be, if you achieve a deep response, then I would just monitor with PCR. But if the patient goes into more like 1%, a little less than 1%, then I would probably do bone marrows once in a while and look at the cytogenetics.
And do these actually make a difference at diagnosis, these additional cytogenetic abnormalities? Because NCCN has said they may. Yeah,
so I would think if the patient goes on imatinib, they make a difference. And then I would be, I would just monitor these patients very closely and strongly consider going to a second generation TKI. For the second generation TKIs, unfortunately, we don't have the data. And I think we should really do that.
ये
as a
कौन-कौन से
community, because it's
जिले
such a
हैं ये हम आपको बता
big
रहे हैं
decision to make.
तो पहला चरण
If you say somebody has isochromosome 17, would you go to transplant with this patient, or would
55
you
सीटें
say
55 सीटें और जो इंपॉर्टेंट सीटें वो कौन-कौन सी हैं कैराना है शामली है मुजफ्फरनगर है मेरठ है बागपत है बुढ़ान
don't consider transplant? But I think practically what we've done in the few patients we have is we monitor them by PCR. If they are in MMR, we are okay with that, and we don't go to transplant.
Thank you, sir.
Ankita, your question.
Hello, Dr. Daneja. That was a really extensive discussion. Thank you. My question is actually a very basic one. I would like to know, sometimes we start a patient on imatinib and it turns out they are not going in a response. So before upgrading to the second generation TKI, we usually go for a TKI domain mutation analysis. So sometimes that leads to a report of no mutations detected. So even without that, we upgrade the patient to a second generation since they have not achieved the proper milestones as required. And sometimes even after using the second generation TKIs, they fail to reach the desired response rate. And once again, the mutation is non-contributory. So most of the times we have seen that the patients might not be very regular on the drugs because of the cost or otherwise. But once that is ruled out, I wanted to ask you, what would your approach be in such a case where no particular mutation is being detected? So how do we proceed? Like, is there a particular flow chart to follow?
So if you have ruled out, lack of access to drug and everything else, or drug interactions, or some people take herbal medications, and so if all that is ruled out, and you are able to deliver an appropriate dose of TKI, and the patient still doesn't respond, I think this is a very individual decision. So I would be happy with less than 1%. So I would not consider lack of MMR as failure. So, but on the other hand, everything between 1 and 10% is more problematic. So I would consider in these cases ponatinib, and then, if the patient, if you still have the same situation with ponatinib, you have a difficult decision. I think quite a few people would argue that if the patient is a transplant candidate, this is the time to consider transplant, because at the time you'll have failed 3 TKIs. Second option is to do some clinical trial. Third option, pragmatic option outside of a clinical trial and in the absence of transplant options, would be to add a hypomethylating agent. So basically combine the last TKI and then add 5-azacitidine, for instance, and hope for a response. At least that is supported by data from several trials. But it's a tough decision, because I think that some of these patients are going to do well, even if you don't achieve a response. I mean, we're not talking about lack of a hematologic response. I think this is then it's really bad. I think then you have to do something. But patients who are in a complete hematologic response, don't have much of a molecular response, but have good counts, good quality of life, that's a tough decision to go to a transplant. So in a young patient, probably, low risk, good donor, probably. Older people, higher transplant risk. No, I would be very, very reluctant to do that. And it's based on, we always do that. It's funny, because then you transplant somebody and you have bad outcomes, so you don't do it for a while. And then after a while, you warm up to the option again. And so we are always, in these rare instances, we always I'm always influenced by my most recent experience, and so at the moment I would say I would rather stay the course.
Okay. Thank you, sir. Yeah, the person I was referring to was in a complete hematologic response, but wasn't reaching the molecular milestones. So, yeah.
So I would if somebody has a complete cytogenetic response, I think it's absolutely fine. So I would not push for MMR, or would not really risk anything for turning CCYR into MMR. Not being in CCYR, that is, I think that is more debatable, because then you really move into a higher risk or higher progression risk bracket.
Thank you.
Thank you. Akanksha, your question.
Good morning, sir. Thank you so much for that excellent overview. I'd like to ask you a question regarding the restarting of the TKIs after the patient has been in a treatment-free remission and starts showing a positive BCR-ABL. So do we start with the same dose as the last dose that we had put the patient on TFR, or is it like a lower dose? We can restart the dose, like suppose maybe 200 milligram of the imatinib or nilotinib, and then probably just monitor the BCR-ABL and then decide on further escalating the dose.
I think that would be, in my mind, it would be safe to do that. You wouldn't have a lot of data to support it, because, as you know, in the trials, the standard was to just start on the same dose. But I think as long as this is a slow molecular recurrence, you're probably gonna be fine. Yeah, I think it would be totally safe to do that. You could also do it the other way around. You could start at the initial dose, and as soon as you have a decent response or the prior response, you could de-escalate. I think this would work either way.
Thank you. We'll come to Dr. Hemant, and before that, one question from the audience. Dr. Samir Shah wants to know, there is a patient who has intolerance to TKIs because of recurrent cytopenia, and you take a decision to now transplant this patient. Is it worrisome if the BCR transcript is pretty high at the time of transplant?
So if the transcript is high, but the patient is in a complete hematologic response, I wouldn't look at the transplant. At the transcript. He should do well, and that's, of course, that's mostly based on patients transplanted prior to arrival of TKIs. So you should not transplant in accelerated phase or blast phase. But other than that, I think that shouldn't make a difference.
Dr. Hemant? Okay, we have Dr. Hemant Malhotra. You had a question? Okay. One question from the audience. Dr. Ashwin Nair, a patient of CML, chronic phase, achieves MMR with imatinib. Then patient defaults the treatment, now presents with accelerated phase. What will be your TKI of choice? Will you go back to imatinib or move to second generation?
So the patient had MMR, then stopped treatment?
Yes.
Okay. If that is accelerated phase, I would go to a second generation TKI.
Right. Okay. That's the last question from the audience. Is there any other question from the faculty here? Yes, Dr. Roshni.
So, if a patient has developed renal failure on imatinib, and the patient also has comorbidities like diabetes, hypertensive, but with a normal creatinine before this, should we always blame it on imatinib and stop it?
I would stop it. I would. I mean, I think it's impossible to rule out that something else might have happened, but I would strongly suspect that imatinib contributes. So I would definitely stop it. And I think all the TKIs do that. It's just, I think it's under our radar many times, but I think they all do it. And yeah, of course you have to hope that renal function will improve, and then have to consider moving to another TKI, but you may have the same issues.
And how do we manage severe TKI withdrawal symptoms?
Well, it depends on what the manifestation is. I think if it's musculoskeletal pain, then I try to do that with non-steroidals, or sometimes a brief course of steroids. I try to stay away from narcotics for all the reasons that we know of. If it's flushing and skin rashes, I try to manage that with antihistamines.
Thank you.
Thank you, Dr. Roshni. Dr. Amit Khurana.
Thank you, sir, for that great talk. This is a real case which I got just 2 days back. A 27-year-old female, newly diagnosed CML in chronic phase. She has come to me with pregnancy. This is the last 3rd month of pregnancy and just on starting of 4th month. So can we go for asciminib plus interferon in such cases?
So she is 3 months pregnant, is that right?
Yeah, it's almost over 3 months, starting of 4th month.
Yeah, I would not give a TKI, honestly. I mean, is she chronic phase?
She's in chronic phase.
Chronic phase.
But the SOCAL score is high.
Blast count is high.
SOCAL score.
SOCAL is high. I mean, I would still try to manage with interferon if you can, because there's no data on asciminib, and most of the known toxicity is first trimester, but I would try to avoid a TKI if you can. So I think last trimester should be fine, but I would try to stay away from the second.
Thank you, Amit. Professor Hemant.
So can you hear me? Am I audible?
Yeah.
Great. So thank you very much, Michael. Wonderful talk as usual. My question to you is how important are the CML leukemic stem cells in the persistence of CML? And out of the various ways of targeting the leukemic CML stem cell, which is the most advanced, which is the most clinical data, which has the most clinical data? Thank you.
So I think that there's general agreement that the recurrence of active CML after stopping TKIs is derived from persisting leukemic stem cells. The BCR-ABL signals that we see in patients on TKIs with a good response but residual disease, at least in some patients, they appear to come from not from myeloid cells, but from B cells, so from long-lived B cells. Now, in terms of how to target CML stem cells, what is the best approach? I would say I'm at a loss, because I think for as far as preclinical data is concerned, there are several pathways that are really heavily implicated. So beta-catenin, for instance, or PP2A, which is a phosphatase. There is evidence for JAK-STAT signaling as maintaining stem cells, but I don't think there is really one unique pathway that is extremely well supported. The problem really is that we haven't been doing the clinical trials to test what is working. So beautiful animal data, but no clinical implementation, unfortunately. So I would love to answer the question, but I can't.
Thank you. Thank you.
Thank you, Professor Hemant. Dr. Sadashivda?
Sir, this is the same question, like the imatinib-induced nephropathy, the serum creatinine is high. So we are, because forcefully we are going for a TFR, so by explaining them. And second one is, can we use a reduced dose of imatinib, like 200 mg? And can we observe this creatinine levels? If it is okay, can we continue the 200 mg or 300 mg of imatinib?
I think one has to try whatever works. I would definitely reduce the dose if you have to remain on imatinib, see what that does to the renal function if they remain in remission. Yeah, I think that there is no standard approach, but I would think that the impaired renal function has then really become the bigger clinical problem. Managing that is more difficult than managing the CML.
Thank you.
Thank you.
Therapeutic, you have a question?
Yeah, my question is about the BCR-ABL transcript. Do we have any criteria to select second generation TKI based on BCR-ABL transcripts other than the regular one?
I don't think so. So I wouldn't really take that into account. I mean, there's data. I think plenty of data that people with E13A2 do somewhat worse in several ways on TKIs in terms of TFR and so forth. But I don't think it would drive drug selection.
Okay, thank you.
Thank you. I have a question. When a patient who is after failure of first 2 lines of treatment, he is on ponatinib. We began with 45 and then came down to 30. And then when we came to 15, he, from a deep molecular response, is now 2% BCR-ABL. Can we safely go back to 30 and keep him on 30 if it works?
I would do that. Yeah, I wouldn't wait until that. You know, if it's creeping up, it's gonna go up. So
versus transplant. He is young guy versus transplant.
Oh.
He's just 36. 2-line failure within 2 years.
Oh, okay. So that's a tough one. I think you could. I mean, if he's a low cardiovascular risk, I think it would be okay to
zero cardiovascular risk.
I would go to ponatinib, 30 milligrams, and not transplant.
Excellent. And is there any place to add interferon to TKIs, especially in these odd cases?
I think you can try. I think it may work or it may not. I think it's hard to predict, but I think it's definitely possible to do that.
One last question I have is, in future, how do you see asciminib versus ponatinib versus the combination?
So that is I think that this question is on many people's minds. So I don't think what we'll see is a randomized trial. They will not do that. So we will have to live with data, with relatively limited data on asciminib 200 in TKI positive, in T59 positive patients. But we won't have a direct comparison. So my personal impression is that ponatinib at the dose it's used versus asciminib at the dose that is currently in the label is better. ponatinib is stronger. So maybe there will be data on asciminib 200 in non-T59 positive patients, that because we would need that, right, to really be able to at least have kind of a fair comparison. But so I don't think we'll get that. So in terms of the combination, yeah, if they allow us to do this trial, we'll learn something from that. Yeah, we would like to do that in all comers with advanced phase CML, irrespective of mutation status.
Thanks. Yeah, Dr. Roshni, you have another question?
In Dr. Agarwal's case, if one ended up with an allo transplant, would one use ponatinib as the maintenance TKI, and how long would one give it?
So I would say if the patient was on ponatinib prior to transplant and maintained a response, then you probably want to use it post-transplant as well. If the patient was on another TKI prior to transplant, I wouldn't necessarily use ponatinib. And one of the reasons is that you'll have cytopenias. So it's hard to use it, and even the other TKIs, imatinib and dasatinib, are not so easy to use. So how long? I think pragmatically, people have given it for a year post-transplant. If patients are BCR-ABL negative, and maintain that for a year and then stop it. If somebody is transplanted for a very high risk situation like progression to blast phase, failure on several TKIs, I would be inclined to keep it on for longer than a year. But this is really not based on data, but more on experience.
And the other thing was, in pregnancy, after the first trimester, how do we what dose of interferon should we give, and how do we titrate the dose?
Do you have access to pegylated interferon?
Yes.
Yeah, so I start at 45 and then go up in weekly intervals over 90 to 135 to 180 maximum. If people tolerate it, you may have to compromise. But I think as long as a pregnant woman is still in chronic phase, I would accept some leukocytosis. I mean, not that much is going to happen. So if you can control the counts reasonably well, I think you can wait out the pregnancy, and then you immediately start them on a TKI.
But breastfeeding also, you can't give TKI, right?
No, well, I don't think there's data for asciminib, for instance, but I think all the others are excreted in the breast milk. So yeah, that's off the table.
Thank you.
Thank you. Anil Tripathi, you have a question?
Oh, not really. Yeah.
Okay.
Yeah, it has been very well answered, everything. Yeah.
Thank you.
Quite satisfying. Yeah.
So is the whole faculty satisfied, or you have any queries? I think they are all happy and they all have exhausted their questions. Thank you so much, Dr. Mike. That was wonderful.
Well, thank you for having me. I really appreciate that. It's a great honor. Thank you so much.
You updated us from ASH. You gave us a number of other studies, updates, and then answered all these questions so patiently. Your answers were very thought-provoking. You spared almost 2 hours for us. Thank you very much for helping and educating us. This will definitely improve the care of CML in this part of the world.
Thank you. Thank you.
Right.
And good luck to all of you. Okay.
Have a wonderful day ahead, and good night, everybody from India. Bye-bye.
Bye-bye.